Hello and welcome to EMS Research with Professor Bram, where we talk about the research-related issues that matter to those who work in emergency medical services. Today, we'll be talking about mental health in EMS. Welcome to the EMS Research Vlog and Podcast from the studio here in Houston, Texas. I'm your host, Bram Duffy. I'm a full-time paramedic on the street like many of you. I also have an appointment as a research fellow with the Institute for Social Innovation at Fielding Graduate University, and I'm an assistant professor of communication at Kennesaw State University. I actually have a research study open now for first responders, so if you don't mind being interviewed by me, then go to my website and check it out, www.professorbram.com. It's professorbram.com. You just click on the current research tab to apply. The other thing to share before we get started, I have written 2 different books on communication. And the most recent book was just released called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. You can find a link to the book below. Also, for sure, hang out to the end and I'll tell you more about it. I want you to imagine being a firefighter, paramedic, or an EMT, and every day you might have to help people during some kind of scary moment in their life, like car accident, natural disaster, somebody's really hurt. And then you learn a lot about how to care for physical injuries, but what about the impact a lot of those experiences have on the person's own mental health? I get a lot of that question myself. How do I cope as a paramedic? And surprisingly, there hasn't been much research or special training to help first responders deal with those kinds of tough things that we see and that we feel. And so, looking at how the United States military helps its Special Operations Air Force pilots with mental health, Dr. O'Hagan thought something similar might help first responders. They decided to test this idea by making a special 30-minute video. And this video was made just for first responders to help them understand and manage their feelings about stress from their jobs. And so in her study, 39 first responders, including EMTs, paramedics, and firefighters, watched this video and another general video for comparison. And after watching, they answered questions about what she learned, how useful the information was found, and how much they could relate to that content. The results were pretty interesting because when asked to choose, about 2/3 of the first responders picked the special video made just for them over the general one. And so Dr. O'Hagan found parts that the video talked about how to communicate better and handle substance use. Those things were particularly helpful compared to just the general video. And so this kind of study shows that first responders really do value training and things that are specifically designed for them and their experiences matter. And this study also suggests that it's important for first responders to learn about taking care of their mental health as part of their ongoing education. And just like we need to know how to treat physical injuries, we also have to be prepared to know that it's coming, to deal with the mental stress of the job. And of course, this is going to help make this much safer. I know that her recommendation when we talked was that mental health training should really be required as part of the continuing education, as we do our certification process. And so this was awesome stuff because right now there's a big limelight in this area. And so I'd like to bring Dr. O'Hagan on and say, welcome, thank you for doing this research. Can maybe you introduce yourself again? I know that I did some stuff, but tell everybody more about you.
Yeah, so I actually grew up in a fire family. So I've grown up in a fire station. My dad was actually one of the first paramedics in California. He was an EMT back in the 70s. And I was on my way to actually a different career when I started EMS because like most EMTs, I needed patient contact hours. I needed to be able to have experience doing it. And so really I was like, oh, you know what? I saw my dad do it. He ended up being in the fire service for 38 years. And my uncle too, he was actually for LA County for 36. And so I was really excited to be able to kind of do what I grew up my dad and uncle going through. And actually, kind of this whole started because I was talking to my union president one day and I was like, if I saw anything traumatic, how could you help me? And she goes, I can't. I was like, all right, this was only about 5 years ago. And I said, isn't that awful? And she goes, oh yeah, but I don't know who to send you to. I don't know like workplace competency, like who would be able to help you. And at that time, we didn't really have resources to be able like specifically dedicated to mental health. And so I was like, I looked into it a little bit more, and that's kind of how I actually ended up going and getting my doctorate at Alliant International San Diego.
Awesome. What inspired you? I know that your family, but you have to decide on what you're going to write about, what you're going to research about. So what pulled the triggers to make those things happen for you?
Yeah, I like efficiency and
Uh-huh.
I know that preventative healthcare in general is always better than like, trying to react after the fact. And so while I was in school, I was learning a lot about military psychology and different aspects of it. And it was super interesting because I was like, the military has all of this research within mental health. And there is one of the up and comings was prevention of when we have people returning from combat deployments, and we have many, many wars, unfortunately, to kind of collect data of what does that look like and how do we best serve the service members as they're returning home? And so that's kind of, been the newer part of military research. And I thought to myself, like, super interesting. We have like that same thing in EMS, like the same calls my dad went on, I'm going on,
Yeah.
traffic collisions, heart attacks, strokes. Like the field, like the calls don't change. And I go, but how are people trained to deal with this? When you go through your EMT training at the very basic level, you maybe do ride-alongs, you kind of go through and you're just like, you learn very quickly whether or not this is a field that you want to get in. And I said, but that doesn't encompass everything. And I was a training officer and trying to help of like, we can't do specific calls. We have to do kind of toolboxes of like abdominal pain, heart, like chest, breathing. And I was like, well, wouldn't that be interesting if we combined kind of the military? We're able to, this is one of the only areas in mental health that we can actually get in front of. Like looking back at, since the 70s from the start of EMS as a whole, and fire was actually, obviously well before that,
Hmm.
but we were able to track certain types of calls like, pediatrics, people that natural disasters, mass casualty, all these types of like we have all of the debriefs and everything that goes in afterwards, but what if we could help support people before it happened? And so that's really where I started to think of we know this is going to happen. Like I know that this call is going to happen at some time in your career.
Hmm.
Wouldn't it be great if we could get ahead of that? The old crew, if you talk about like what old EMS looks like, the suck it up buttercup, like
Yeah.
just get through it and go through. As I was starting to kind of like, do I want to switch careers? Is this, becoming a psychologist? Is this something that I want to move forward with? I was talking to my uncle and he said that he's unfortunately experienced 5 suicides of his fellow firefighters within his 36-year career.
Hmm.
And to me, that's too much. And so kind of really looking at all the statistics of there's so much room to grow here. And I love the resiliency of the field. Like, to go through that training, to be able to help people in crisis, first responders have that built in. And I also thought that what a great population to work with because they stay calm in a lot of crisis scenarios. They do all like they have so many resiliency skills built in that, let's give them something else that they can use. They use the tools, they use their protocols, they know what to do. Let's give them something else to work with.
Yeah, and these first responders are very keen on what happens on these suicide calls or these depression calls, right? And so, gosh, it means that they know the right things to say so that they don't have to go to, the mental hospital, or they don't have to, you know, to, they just, they're a different approach as a person, and I think that there's so many things that we can do to make this better, and part of working towards that was your study and what you did in your study. So I know that I gave a little summary, but can you help me again? Like, tell me more about the videos that you made, and like how, what went in that, and how does that create it, and because I know that you had some regular videos, but give me like a better gist of what the deal was for this.
So for those who aren't quite familiar with the PhD process, is that the difference between like a master's level and a doctoral is a dissertation project. And so oftentimes a dissertation is kind of contributing back to the science, back to the field of looking at, and so I had to do a full literature review, full study. And I had my previous research had been with children with ADHD and autism and doing an intervention study. So I had known right off the bat that like I didn't want to do a survey. I was kind of kicking myself years later as I was deep into training and had 80 other things going on. But I really loved wanting to have like an actual tangible item to do. And so, kind of that inception, and as it goes through, Dr. Stephen Thorpe was actually like really pivotal in helping me design the research project itself. So he was my chair at Alliance San Diego, but he has an extensive career as a board certified licensed psychologist in PTSD, and he actually ran the South County PTSD clinic at the VA. But more importantly, he's also received millions of dollars in NIH grants. And so one of the studies he did was the effectiveness of telemedicine back in like the late 2000s. So him knowing kind of how to actually implement these types of projects and like what interventions look like. And I told him what I wanted to do, and he said, how do you know they even want that? How do you know? Like, let's start, like, you're assuming. He's like, you're assuming you're taking a, couple steps forward. You're assuming that they want. You're assuming that this is something that they want, that they need, and that they're actually going to use. He goes, let's start your study off at ground level. Let's see if they even like the content that you give based on the research that you find, based on background. Um, and so and he said, in order to do that, in order for them not to be like, yeah, yeah, this is really good or whatever, we need a control video. So kind of anything that you would see on YouTube, anything that would be pulled for groups, like just kind of basic content made by licensed mental health professionals. And so he goes, that way you're getting, what kind of the training that you've been given before, and now that you're comparing it to content that of like, okay, this is something that I can actually use. And so that's kind of how it became. So that's why our main video was 30 minutes, because I was actually able to offer my participants one CE unit towards their certification or licensure as a part of compensation. But really that kind of development of like, okay, what do they want to see? During my training in grad school, I worked with active duty military. And so I kind of used what we were teaching them of like, okay, like here's how we go through different sleep hygiene techniques,
Mm-hmm.
especially being deployed or out,
Mm-hmm.
kind of, what that looks like, communication tactics, which is how to communicate with your partner. First responders do an excellent job of closed loop communication. It's trained in from the beginning, and that works when everyone's on the same page and everybody knows what to expect. But with the divorce rates, oftentimes it's this kind of disconnect with their partner on how do we communicate? So using DBT interpersonal skills like dear man and give and fast of like, how do we also bring in like the directness that you have and the efficiency that you have into a relationship that doesn't know how that operates? So that was one of those. And then mindfulness, like something that first responders actually do very well is mindfulness. And it's kind of, it feels like this really off term. And I know I'm teaching a mindfulness-based stress reduction group right now. And the first thing I get is like, how is meditating going to help me feel better? And, really, I'm pulling in from their training. Like when you're on a call, you're on a call. You're not sitting there, you're not thinking about what you have to do later, you're not doing this. So also really pulling in strengths of things that they do very well. So that was kind of the core basis of what I was looking at within the video itself. And then I really wanted to highlight substance use. Um, the what first responders do very well is peer support. They utilize peer support more than any other population in the country.
Mm-hmm.
However, the second coping skill is alcohol.
Mm-hmm. Mm-hmm.
And the lifetime alcohol prevalence rate for first responders is around 47%, which is 2 to 3 times higher than the general population. So, with that segment, it wasn't really about like, here's how alcohol is bad for you, and here's this. It was, hey, just a heads up, this is what we're looking at. But then within that segment, highlighting peer support, highlighting PTSD symptoms of like tend to be like more PTSD symptoms. We see a higher alcohol use level. Like notice if people around you are starting to drink a little bit more, they're starting to act off, like really using that section as like an empowerment section for them. Hey, like if you see something, say something, like,
Mm-hmm.
start to notice, call it out, don't just ignore it or chalk it up to something else. So that was all packed there in the 30 minutes, but really being able to take that specifically and then compare it to, hey, get 8 hours of sleep. The other issues that I've kind of run in with both personally and professionally is this idea that we're having non-licensed clinicians give these types of information. We're kind of either having people in a leadership role, we're having supervisors get it, and we're not getting people to have it standardized really, and kind of like how that information is like, out to, to the first responder community. So I think that's also something to kind of take into of like how much are we actually seeing mental health within these different departments and different agencies. Like what, everybody knows you have to do something. My goal first, overall is just also reduce stigma around it. Like one of the things that I do with my veterans is really talk about psychoeducation and like what does PTSD look like? Like, first of all, like what are the symptoms of it? And to take that kind of to first responders, and a lot of departments are doing very good jobs on suicide and PTSD, and that's kind of the sole focus. That's where everybody's kind of pushed forward. But the reality is that it's kind of the death by 1,000 paper cuts. It's the burnout, it's the call volumes,
Mm-hmm.
it's the quality of life and stuff. So hopefully getting departments like even as a first step to recognize that yes, while those big ticket items do matter, we do need to be working towards things, you know, t- talking about mental health and doing things that are proactive within your department or agency that is meaningful to the people that work there, not just something that admin can check a box off or send something out or like, here's this memo or like, reminder, eat your fruits and vegetables, like, doing a little bit more of a deep dive into what we can do as a long term, getting that conversation even started, because I feel like
Yeah.
that's what's really missing across the board. I know within AMR here in San Diego, I'm actually one of the heads of the peer support program. And while I'm unlicensed, just sticking to just what peer support is, active listening, resource based. I actually redesigned it with that thought in mind that, a first step could be peer support, like being able to just normalize and the critical stress incident management of not just doing the debrief, because I feel like that's where everybody becomes very frustrated is that they just get the debrief, right? There's a critical
Mm-hmm.
call, this happens, they debrief, and then they never hear from it again. It's actually one step in seven. And so for me, I kind of treated our peer support like that, where it's like, okay, so you reach out, we call, and we continually do follow-ups. And we have people who are chaplains, but we have people part of the LGBTQIA community. We have people that are parents, new medics. Medics have been around way longer than I am, age-wise. And, having that diversity of being able to cater to everybody's specific needs. And I feel that a chaplain-based model is great starting point of like, okay, how do we have somebody who's trained into being able to listen? And sometimes we need more than that. And getting departments to, once again, going back to that, this can't be a check the box. This can't be like, well, we have a chaplain, so that's our mental health
Mm-hmm.
services. Bringing in people, and I think this is also really important to emphasize that people need to be competent in first responder culture
Mm-hmm.
to be able to be like, you should like really decrease your caffeine use is immediately going to shut somebody down. They're
Mm-hmm.
like, cool. I know in one of my units, I was averaging 20 minutes of sleep at night. For someone to be like, you should stop your caffeine use. And I was like, cool, well, then I got to drive. Like, wish me luck. And kind of that understanding of something I've noticed when talking to paramedics and firefighters that also really, really matters of not having to sit there and explain a Kelly schedule, not having to sit there and explain what we go through. And I think when we talk about like civilians first versus first responders, the public grows up with this idea that when you call 911, these very competent people will show up. It's cool. We got this. Everything happens. Then you see somebody in your office who's going, I'm really struggling. I saw this kid, I did a child CPR, all this happens, and they start crying. Well, then the feedback is, I must be messed up. Like if I can't be doing this. So really having somebody who's trained in their reactions, not doing the questioning of like, well, what's the worst call you've ever seen? Like, any first responder listening is like rolling their eyes, like, you hate that question.
Mm-hmm.
And so, how do you approach some of these? Because some of it is like for me with PTSD training, I have to ask why you're here. I have to, but the way you ask it and how we go about it and really working up to it and really being careful of how we phrase things. I have a veteran who is a first responder, and somebody told him was like, you must like, trauma, or you must like that. And he's like, but I'm trying to help people. Like, and so all these kind of like that matters too. And
Mm-hmm.
I think that, it's not just any clinician can do. We can't just take anybody off the street and be like, hey, start to see these people for PTSD or start to do this. It really needs to kind of be, what does the field need? And I think that just goes kind of as I'm, keep going back to it of, you got to ask your field, right? Like, I think a very solid peer support does wonders. They want to be able to talk to others and just have a casual conversation with not having to worry about if you're going to report this, if this is going to happen. And the way we do it here at AMR is we built it into teams. And so it's not this free floating pool that the same three people get called up all the time. We rotate through different teams. So the pressure is not always on one person, one specific. And we do continual follow-ups. It's not just the one, hey, let's do this. We do continual follow-ups and having it. And for most people, they just needed someone to talk to. Like, yeah, this was awful. I didn't know what to do. Thank you for normalizing some of this for
Mm-hmm.
me. And they're fine. It's like, okay, having a very solid foundation and then being able to offer, like, okay, with peer support, they very much know their role. A lot of my peer supporters very beautifully have said, like, my goal is to walk with you. If I have to start moving forward to guide you, you need to go for professional help. We need to have that next level. And sometimes having specific training on, suicide prevention, PTSD, as all the symptoms that you mentioned, sometimes that is really what's needed. Like, hey, let's work on those coping skills. Let's build some of this up. Let's look at this from a different perspective. Because my job isn't to tell people what to do, it's to help build insight for what they want to be able to do. And I think for departments, having somebody who doesn't do it for just fit for duty evaluations or somebody else that's kind of just the head, But what the Defender's Edge study that I quoted was the benefit of having somebody embedded within the
Hmm.
community, that they were there at the trainings, they were there at their, their all their drills and things, that they were a part of the unit. So when people had to go talk to them, that was the first thing. They were like, cool, I don't have to worry about this person. Like, who are you going to tell? How's this going to get
Hmm.
out? They went to them, they were able to talk, and that person was seen as a respected member of the population. And so for me, my benefit is that I've been within the same community for 6 years. So when I was doing this research, people were like, oh, this is what Jacqueline's doing. She's not just talking about school, she's actually going in, and they were more willing.
So many times, like you said, that this just gets put off, where or it's suck it up, or like get your act together kind of thing, or I've seen people that have been told quick and in a hurry that maybe this isn't the right field for you. You can't keep can't keep it together. And so normalizing the fact that these are the problems, that it makes a big difference. So this is all great. Thank you so much for joining me today. I appreciate you. And those folks that want to reach out to you, I'll have your contact information down below for them to reach out.
I just want to give a quick shout out to CAPC, the Commission on Pre-Hospitalization Education. Jay Scott was instrumental in helping me make sure that our all my participants in my study were able to receive their unit to go towards their either certification or license. So I just wanted to say thank you to them for their support. They also did social media blasts for me to because they have really valued and personal conversations with Jay Scott of what they really want to start seeing the field move towards too. So I'm very excited to see what's going to be up and coming here in the next few years.
For real. Good deal. Thanks, and good to have you here. For this next segment, I'd like to talk to you about the First Responder Behavioral Health Institute. The First Responder Behavioral Health Institute serves as an international speakers bureau that unifies first responder change agents. Many among them are published authors and renowned public speakers. The Institute showcases an impressive array of talent, deploying it upon request to first responder agencies both nationally and internationally. It offers unique courses that are hard to find elsewhere, with many of its programs qualifying for continuing education credits towards license renewals across various locations within the U.S. In response to a growing epidemic of first responder suicides, the acknowledgement of inadequately addressed EMS mental health service calls, and just a real profound understanding of the pivotal role of org psychology and leadership development. These things play a role in safeguarding the first responders' mental health and also ultimately protecting the public. So the First Responder Behavioral Health Institute is established as a nonprofit organization led by Joseph Burgundy. And I've invited him here to meet with and talk about what he does and his mission. He's a psychotherapist, a crisis counselor, and educator who has served as a first responder since the age of 17 and currently holds the position of clinical director for a crisis response team that specializes in providing on-scene crisis counseling services to first responders during and after critical incidences. He poses deep passion, for serving on the front line with public servants. And he's a multi-state licensed board certified psychotherapist, as well as the founder of the Institute. He also founded the Counseling Center of Texas. So before we begin, can you tell us more about yourself? Is there anything that I missed?
Bram, I want to thank you so much for inviting me on your podcast today. It's an honor to be here. You summed it up very well. I've started as an EMT at 17, paramedic at 21. 35 years in emergency medicine, critical incident work, ER, ICU, CCU, and then moved into the behavioral health side when I was starting to come to terms with and realize that suicide was something I was seeing a lot of in our colleagues. And here's a population that has dedicated itself to saving the lives of others and you're not expecting to go ahead and see an increased population of suicidality in police, fire, EMS, and in our emergency physicians and nurses as well.
These are supposed to be the superheroes, right? The folks
Absolutely.
that get us out of these bad spots.
Yeah, yeah. So, as you had stated, I founded the Counseling Center of Texas first, and have run that agency now for just over 10 years, and have been in a situation with it where we've grown it statewide. Telehealth has helped a lot, and our crisis response teams started there, and we went ahead and we moved those over into the First Responder Behavioral Health Institute. Our crisis response teams are all clinical mental health counselors, therapists, social workers, psychologists, and we go on out on scenes and work with agencies in 4 states. I'm licensed in Texas, Washington, Oregon, and California. And we'll go ahead and we'll respond to line of duty deaths, critical incidents, mass casualty incidents, and kind of give them background psychological support and help them with that deployment. But, that's not how we love to come into agencies. We love to come into agencies because we've been invited there to go ahead and do an education and training, wellness, and some of the more preventative programs that go ahead and increase resilience and help keep our workforce safe, healthy, and in the game before they encounter these critical incidents.
So what all have you all been accomplishing with this infrastructure that you have going on?
Well, the Institute was born out of a recognition of 2 things. The recognition that, and having been a former teacher of the paramedic program and EMT programs, I recognized very quickly that we simply don't have the behavioral health component in there. Most paramedic manuals have maybe 15, 20 pages tops on behavioral health, and most of it is chemical restraint and safety and security issues to kind of keep the scene and yourself out of harm. Nothing in de-escalation, nothing in crisis response, nothing in understanding the signs and symptoms of psychosis, schizophrenia, and how to go ahead and work with somebody who's having a behavioral health emergency. So when I recognized that, and that was born out of the trainings I was already doing for police and fire departments, I recognized we needed a more comprehensive curriculum. So I set aside the time to put together the first program, and our programs now are over 400 hours in training that first responders can get in areas of crisis de-escalation, behavioral health, first responder, and a lot of courses that you can find on the platform. But then it also became very much into my awareness as we started doing more crisis response and more clinicians were needed on scene, that our clinical partners didn't have the first responder background either. A lot of great education in graduate school, but they also don't teach you how to step out of a police car, a fire truck, or an ambulance and to offer on-scene crisis response. So then we started up a behavioral health clinical responder component. So we have the behavioral health first responder and the behavioral health clinical responder piece to our programs. And you don't have to sign up for any of that. You can take it one class at a time. And if you decide that our world-renowned team of instructors is starting to resonate with you and you're learning, you can hang around for a couple of years and take about 15 to 20 courses, and then you will matriculate out of that and be able to get the certification that I just described.
So you have a lot of stuff going on, and I'm thinking about just how awesome this is as a resource, because for a lot of folks who have mental health problems that are first responders, there's just nowhere to reach towards, or the place may be the right spot but just not appropriate, or there's so many different things. And so I want to ask you, the incident that I am familiar with that really affected my own PTSD, as severe as an incident as it was, I don't know that having a debriefing would have totally fixed me, right? And so I see the emphasis on, making it to these people right after the incident, but then what about later? Are you a resource for helping people who have problems far after the incident?
Absolutely. We do provide trauma and crisis services, and we certainly are there. But I love what you just said, and it resonates strongly with me. Having a critical incident stress debriefing and having a team come out is of value. However, a lot of times the strength in your organization will affect and determine how good that team is. Not everybody is ready for a debriefing after a critical incident. And one of the things we see is that people mandate. You've all been voluntold to be here, and here comes this person in our agency. And that doesn't always go well. So a lot of folks are recommending now that we start to move away from a debriefing model and come on over to a diffusing model, to where you don't have to talk about it. And the very first thing I do in my clinically directed debriefings and in my peer support team work is let them know that you are not obligated to say anything. Your mere being here is enough to go ahead and provide support and structure and comfort to your colleagues. Now, hopefully, I'm going to educate you a little bit on the signs and symptoms of post-traumatic stress, so that you're watching for them in yourself and your colleagues over the next few days, and able to go ahead and start addressing those. And this gives us a point and an opportunity to make that first contact. Regrettably, agencies tend to call us out afterwards, so it does end up tending to be a debriefing. And then we kind of move them in from CISD to CISM, which is more of a long-term management program. Our best practices. We don't want to be coming out there for debriefings all the time. We want to be a regular part of your agency. And that's, how the paradigm is starting to shift now. And instead of just calling us out there once or twice a year when there's been something horrific, what is it like to go ahead and integrate, professional mental health people into the system? When we started doing that 50 years ago in the fire service, they said it can't be done. I remember as a young man hearing, I don't want nurses in my ambulance or in my fire truck. And then, pretty soon there was a rescue truck at every station. And then we integrated paramedicine into the fire service. And some models use that and some don't. I think you already know the saying, if you've seen one EMS system, and you've seen one EMS system. So it's done differently all over and so are these different models. We're starting to see integration models where I recommend clinically directed peer support teams. So you have a clinician that you've established a relationship with. So when there is a critical incident, this is a familiar face coming on scene at that line of duty death, who's coming on scene to help you guys with a triple homicide or the loss of an infant and something of this nature. And it's somebody who's been riding around in your vehicles, who's comfortable with how you operate. Maybe they even carry a city radio, and they're part of the team. So that's one aspect of how things are changing. Another one is a co-responder model, which is something else that we teach, to go ahead and get those clinicians ready to go ahead and serve. And new systems are emerging all over the country. I think about Dallas Fire Rescue has something called the Right Care Program now. This program has a Tahoe with a police officer, a firefighter paramedic, and a mental health professional in the ride, all in plain clothes. So they're reducing that sense of threat. Now, there is still, responding, police vehicles and other vehicles that are on scene to provide help, but using a much more non-threatening approach as we go ahead and try to negotiate and help people navigate their own mental health trauma. That's just one of the models. A similar model is available, and Alameda has the Alameda Care Team for Alameda Fire Department. And they run a model where they'll go ahead and have a clinician available by phone, similar to the way paramedics use the medical director to patch in. In Colorado, the City of Aurora and Aurora Police Department has integrated units where you've got two therapists going out in their own vehicles, responding alongside police, fire, and EMS. In the city of Lubbock, Texas, Lubbock Police Department has 40 therapists, and they're out in two of them to a unit, and they have a victim services model. So you're starting to see various models pop up all over the country, some of them completely focused externally, dealing with the public, and many of them focused on our own employee health and wellness, organizational development, mental health services, and referral services for our members. So, and this model is starting to be called a co-responder model. that gets those clinical mental health people integrated into your system. Police departments have done this the longest. The police psychologist is a pretty well-known thing.
Mm-hmm.
But now, how do we integrate the mental health professional into the fire service? Do they work with our people and do our education and training in our own mental health? Some of them, which Dallas has a couple of social workers and licensed professional counselors. All they do is work with the members, over 2,000 members. Then that Right Care program, where that is a push towards mental health towards the community. So various models are creeping up. We teach this program as well, mobile integrated healthcare, and it's complex. Every time we have to sit with that city and say, what is your design? What is your desire? Where is your police, fire, EMS agencies, your medical directors at in this process of providing and integrating behavioral health into a first responder community? It's a lot of fun, having sat on the back of an ambulance since the age of 17 and being out here now as an experienced clinician, complex trauma specialist, and a crisis team leader, starting to see that, I was there when the doors opened and paramedics stepped foot into these roles and achieve their independence. Now we're fast forwarding and we have clinicians getting ready to join those ranks, and that hodgepodge is coming together, and we're starting to see these models come into being.
So the Institute has speakers, and you do training, and you try to partner with agencies who are looking to help their people and also to set up models for how they practice. Is that?
Absolutely.
That's all this stuff. So, gosh, it's a lot. And so what about the average first responder who isn't happy with their counselor, or, is interested in finding someone that has an EMS or law enforcement background? Do you cater to those folks through telehealth also?
We do, and we do it in those 4 states. But I also want to say this about that. It's a good thing and a bad thing to have a therapist who has a first responder background. It is a good thing because we can relate to them, and we understand because we've been out on that truck, we've been in that police car as well. But there's also a point where, therapy and being a therapist is its own clinical specialty. And what I encourage my first responders to do is they'll often say, I went to a therapist once and they sucked. Yep, that's absolutely true. And you've been to probably a few other physicians and you didn't go back either. So I go ahead and ask them to please, when do you stop trying to teach a child to walk? And the answer to that is always when they're walking. All right, so you go back until you get it right. If you needed a specialist, please go through 3, 4, 5 clinicians. Give each clinician 3 sessions. It's going to take you that long to learn their style and what they're about. And when you're interviewing clinical mental health professionals, ask them the question and the power of their why. I want to hear when I'm working with a first responder, I want to go ahead and hear, and myself in my own treatment, what I want to hear out of my clinician is, hey, I've taken extra classes above and beyond my graduate level training. I'm trained in complex trauma medicine. I'm trained in eye movement desensitization and reprocessing. I understand traumatic related dissociation. I've taken extra courses in that. So you're going to want to see that these people have specialized, that all of medicine is specialized, right? You don't go ahead and take a cardiac patient to a foot doctor, so there's this assumption that all clinical mental health professionals are the same, and that's not true. We do have the graduate degree. In order to get an independent license, you need 3,000 hours of training, and that's a lot, but now that I teach the subject, I say that's enough to get you through and licensed. Then the specialization begins, so whatever you're wanting to specialize in. For me, it was complex trauma and traumatic-related dissociation, post-traumatic stress injuries and disorders. And I just went to town for a couple of years, really trying to understand that and to try to add as much value. And I'm learning every day. New things are coming out, and I'm constantly immersed in that area study and always looking at those evidence-based best practices. So those are the kinds of things when you're interviewing your clinician. Unfortunately, it's possible to go ahead and sit through an 8-hour course as a therapist and get yourself a really shiny certificate with a beautiful seal, and it says something along the lines of for a certified first responder counselor. And in 8 hours, the certificate may be shiny. But I've heard more than one person come into my office and well, dude, I tried to explain the decapitation or the car rollover, and the therapist started hyperventilating and
Right.
almost passed.
Right.
So
When we work to find these folks, sometimes it's insurance dependent, and we get pigeonholed into situations, or we have long wait times to be able to get into the right person. And so that's why I'm appreciative of telehealth, and I'm also appreciative of just the work that you do, because there was a time in my life where I didn't know this specialty existed. I didn't know that the folks like you were out there to help folks like me.
and that's another thing too. This is growing all the time. When I started, there really weren't that many people doing this. And I want to say this: if you've got a bachelor's degree in anything and you've served as a first responder, very quickly we start realizing in our 40s and 50s and beyond, those back muscles and neck muscles aren't the same as they used to be. And we might have topped out in our career as a police officer, a firefighter, a paramedic. Going back and getting a graduate degree, a master's degree in clinical mental health counseling, licensed clinical social worker, licensed marriage and family therapist. These are about between 2.5 and 3 years of graduate school. And you're going to go ahead and graduate and be eligible for board certification, another 3,000 hours. So you're looking at a 3 to 5 year process. But at that point, you are able to hang a shingle. You're able to go ahead and see clients on telehealth in person. And, in my instance, that led to licensure in 4 states. And at that point, you can specialize in whatever you want to. And then continue to take courses to improve. And in the whole process, you're improving yourself, right? I mean, I have also recovered from my own post-traumatic injuries. And this is a process of lifelong learning. If you think you're going to get in with a therapist and they're going to go ahead and fix you in 6 sessions or less, I'm here to tell you something. The only people that think we can do that are insurance companies, and they want a solution-focused model. And complex trauma models take a lot more to learn. And an average course of therapy can take a couple of years. What are the benefits from that? Longevity on the job, understanding your strengths and weaknesses, your personal relationships improve. I beg my first responders, please do not let and wait when I do my debriefings. Please don't wait until the divorce papers hit. Please don't wait until you've gone through your 2nd, 3rd, or 4th police or fire department every 2 to 3 years before you sit there and go, okay, something's not working out, and I finally figured out that something isn't always them. Mm-hmm. I have to go ahead and look at myself, because they're not processing their post-traumatic stress. Those levers of anger and the rage and all of the ruminations are still there, and they haven't learned how to process that. And that is some tricky stuff, and it takes some time to do that. There really is a rewiring of the neural net, and teaching them to go ahead and move out of that amygdala response into the frontal lobe. So there's a lot of brain science behind what we do, but it takes a quick minute, as they say in Texas. We can't do this in 6 sessions. And waiting until, you've already been suspended or the divorce papers have hit and expecting me to perform a miracle in 3 sessions is it's not realistic.
Yeah, and what I like to say is that there are, this is a physical injury just like a broken bone. And we don't recognize it as a physical injury. We think of it as in some other category, but we're still a human. So,
I'm glad you mentioned it. And I like to link the brain up with the rest of the body, because this is true. Another one of the problems that we face is the stigma. Mm-hmm. People will assume, if you've had if you've broken your leg in 3 places in the fire service, we've immediately got a treatment plan for this. You will go through physical therapy, occupational therapy. You'll meet with a few people. We'll get you back up and running and back on the job. 3 weeks, 3 months, we don't care. We're going to go ahead and do that. When somebody goes ahead and calls out and says, hey, I've been diagnosed with post-traumatic stress disorder or injury, Many leaders don't know how to handle that, and they don't understand how highly, highly treatable this is, and how most of the time, I would say 85% of my patients, they may have to come in and see me a couple times a week for 6 months, but they're able to go ahead and return to work. And there's, a couple of the people that we've interviewed on our own podcast. Michael Segru, Walnut Creek Police Department. He ended up retiring on a medical, and now has this wonderful book called Relentless Courage, where he really helps officers to understand how to move that leadership along. Then we have another author we work with who is actually a member of our faculty, Mark Bouchard, Royal Canadian Mounted Police, had a similar diagnosis, yet he was able to stay in, and he's a SWAT team commander for them, or operative, and he also is now a member of their wellness teams and stuff. He had to teach them, look, this is recoverable, and both men have recovered substantially and significantly, and but unfortunately in one department, in one area, they didn't know how to navigate that as well, and in the other, they, after some education, teaching, and reteaching, they were able to go ahead and see the benefit and the value of understanding this and working with it. So, yeah, the truth of it is the brain is a part of the body, and if it suffers an injury and that injury is treated properly, you can return to work, you can return to your profession most of the time.
This is exciting because this is not the way it was 25 years ago when I started. Folks just dropped off and they're stuck. So before we go, I'd like to, I watched your In Route podcast, so I want you to give a good plug for that so the other folks who are interested can join in also.
Thank you. The En Route is the podcast of the First Responder Behavioral Health Institute. And the reason that came to be is you don't have to be a member of the Institute to be interviewed on this podcast. You have to be a change maker in this space. When I put this together, what I wanted to do is teach leadership and organizations that there are plenty of resources, they're just not being sought out. So I went ahead and I started looking for some of the best authors who speak on this platform. Frank Viscuso, Step Up and Lead, a world-renowned organizational development expert, has been on our show. And he doesn't work for the Institute. He is his own agency. And please call him. You can also take leadership courses with us. I don't care. I care that you're growing your agencies. And so I try to interview some people that are really change makers and constructively disrupting things. We've had Jason Patton on, hilariously funny. And that funny man is known by his image all over the world, still an active firefighter paramedic, but actually gave us a very deep and heartfelt interview on suicide loss. We've had firefighter Fenton on, and we've had, oh my goodness, Dr. Olivia Johnson from the Blue Wall Institute, who talks about the Fatal 10. We've had Daniel Sundahl on, and his artwork is known throughout the world. As a matter of fact, Daniel, a firefighter, paramedic, and a world-renowned photographer and artist, has gone back, and he is about ready to graduate with his counseling license in Canada. So that's a story, and he teaches a class on our platform about post-traumatic growth. Nick Arnett has got resilience courses out there. And his books, he's with CAL FIRE. So, I interview people who are with the Institute. I interview people who are not with the Institute, but they're change makers in this space. They're making a difference. And I want to make every effort to get them out there and get them the exposure. So the En Route podcast was all about trying to go ahead and help these people come together on a common platform to spread the message that change is here. Change agents are available. So if you're lecturing in police, fire, EMS, behavioral health, psychology, organizational development, reach out to us, and we'll do our best to see if you're compatible for one of our podcast episodes and or live streams, and we'll go ahead and schedule that. We're now in season 3. Season 2 is just starting to drop May 1st.
Yeah, well, I think the intro alone is like the catchy music, and the intro alone is worth watching the En Route podcast. So you guys do some great work on there, and I encourage folks to go there. And I'll put The link to the In Route podcast is along with the Behavioral Health Institute link and your contact information up for folks. And I just want to thank you for joining us.
What an honor and a pleasure to be here. Bram, thank you for inviting me. I'm very grateful.
I want to also invite you to check out my latest book. I co-authored a book with 4 Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis. So I just wanted to invite you to check it out because we introduce a method for communicating with patients on the scene of an emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. You can follow a link below or find it or go to almost anywhere books are sold. If you contact me with proof of your order, I'd be happy to mail you an autograph sticker that's designed to put in the jacket cover. So send that over my way.
Hi, I'm Will Chaplot from the International Pre-Hospital Medicine Institute. You might know about us because of the literature reviews that we post every month free for your review on our website at iphmi.com and also published through GEMS Online magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference, whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field or what we should be doing in the field or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here, and all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials. Relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon. Thanks.
I'm doing a research project related to first responders who live in the United States, and I could use your help. If you don't mind being interviewed over a video call, I'd like you to go to my website and fill out the form at www.professorbram.com. It's professorbram.com. Thank you again for listening, and I look forward to sharing more insights with you in the next episode. If you enjoyed EMS research, please tell your friends and like, share, and subscribe so that you help others get this message.